Ready to go. All right. Welcome. Thank you so much, everybody, for joining us today. This is our first ever talk on HIV in Montgomery County. We'll be doing these monthly. I'm going to tell you more information about that. But in the meantime, my name is Emily Brown. I am the EHE, Ending the HIV Epidemic Program Manager for Montgomery County. And today's conversation, which is also a great learning opportunity because of our fantastic panelists, is about HIV in women in our county. And I want to take a moment to introduce our amazing panelists who each of these people I could talk for the whole webinar about because they're so amazing. And I'll start with Dr. Hazel Jones Parker. And if panelists, I'm gonna actually go ahead and unshare while we do this so you can see folks' faces better. Dr. Parker is a director of clinical education at the Institute of Human Virology and assistant professor in family and community health at the University of Maryland. And she's a nurse practitioner specializing in HIV. We have Dr. Jessica Rosen, who's board certified in infectious disease. Dr. Rosen completed her training and then was on faculty at Georgetown University Hospital before coming to Montgomery County Health and Human Services to work as a staff physician with us here at Dennis Avenue in the HIV clinic. Welcome. And she is also the medical director of our STI clinic. Ms. Paulette Johnson is a community health worker at the Women's Collective in DC, where she has been since 1993, doing amazing work, advocating for newly diagnosed people living with HIV and helping to keep them in care. And Paulette is a mother of 5, a grandmother of 14, and has 2 great granddaughters. And she says, rather than the other way around, HIV lives with me. And last but not least, Chantel Thomas is a public health services specialist at DC Department of Health, helping folks get access to pre-exposure prophylaxis, PrEP. We'll talk about that today. And she is the CEO and founder of Pretty Periods and a women's health advocate who's a great asset to our county and our DMV community. Going to go ahead and share my screen again and get started. So yes, like I said, go ahead and use, can y'all see this? Mm-hmm. Yeah, okay. Yes. Use the chat. We will be available, myself, the moderator, Emily, and panelists will be available to answer questions, but we will also have a Q&A period at the end. And if we don't get to questions during, we can definitely get to those after. So I wanted to, before I say anything else, remind everyone who works for Health and Human Services or who's out there in our community and needs HIV or STI testing, services, prevention, information. We are here at Dennis Avenue Health Center. We are open for business. We do free and low cost HIV medical care, wraparound services, case management, HIV and STI testing, treatment. We provide dental care for people living with HIV, and we do provide pre-exposure prophylaxis, which is an HIV prevention medication we'll talk more about. And that's our contact information, but you can contact me too anytime, and whatever it takes will get you into care if you are looking for HIV care or prevention anytime. So please stop by. We are here. Wear your mask. All right, so we are gathered here because of a federal program, a very collaborative federal program that's very exciting, the Ending the HIV Epidemic program. And it's an initiative that's a very ambitious initiative to reduce new HIV infections in priority jurisdictions around the US by 90% by 2030. So my whole job is dedicated to bringing all these pieces together and wonderful folks like the ones on our panel to take all the knowledge that we've acquired since the beginning of this epidemic and put it to use in the communities that need it most. In Montgomery County, we are very lucky to have this initiative, to have been selected. We are in good company. Our neighbors in Prince George's County, DC, and Baltimore also have embarked upon the EHE, Ending the HIV Epidemic planning process. So we collaborate with them, with the state of Maryland, with DC, to do all sorts of great new work. Again, taking what we already know, all the tools in our toolbox and getting them out. So it's an infusion of resources, knowledge sharing, And we're able to do stuff like this, which is fantastic. I also want to give our partners at the AETC a shout out at University of Maryland for providing CEUs for this educational session, because we know that you all in our workforce, in our amazing, robust county workforce, need to keep those up to date. And we are excited that you chose HIV as a topic today to increase your knowledge. And we also have, I think, lots of opportunities to collaborate with you all in your different areas of service to our community. So I want to give you some data about HIV in Montgomery County, especially among women today. But I want to give you just a caveat that the data doesn't tell the full story. And there are a lot of ways you can look at this data, but the people and the humans that we're going to talk about and talk with are really the important piece here. So we've seen how an epidemic can impact our community. Obviously, HIV has been around for a very long time, and it's very reductive to kind of look at charts and graphs and say that this is the problem that we have in our county. HIV is one of many health issues, health equity issues that we're grappling with, and none of us lives in a vacuum, of course. So just fast facts. Again, you don't have to memorize anything here. I will send out all this information and some more really great data sources from Maryland Department of Health, the EPIs who compiled this data and who analyzed it for us. There are about 4,000 people living with HIV in Montgomery County, and there's quite a large proportion who are actually undiagnosed. So out there living with HIV, haven't been tested, haven't been given a diagnosis. And that's a big problem. We also have quite a significant lag time between when a person is exposed and contracts HIV and when they're actually diagnosed. And that's something that EHE is also hoping to remedy. So 135 people were diagnosed in 2019, just to give you like the kind of latest year's snapshot. And you can see the way that sex assigned at birth men and women in this graph has changed over time. This is the proportion of people who are newly diagnosed. So 62% were male last year or in 2019, 39% female assigned at birth. And this is just kind of our general snapshot. Something interesting to know and something that makes our county rather complex is that about 30% of those who were diagnosed in 2019 and about 40% of people living with HIV in our county were born outside of the US and come from a variety of places, have a variety of cultural and linguistic nuances. And it's something that characterizes life here at Dennis Avenue Health Center, our Ryan White funded HIV clinic in the county, and presents some opportunities and challenges for prevention and care. So something that we want to think about a lot. But today we are focused on women, and I'll get to that in a second. But in HIV and in public health, we think of a continuum of care. So there's the folks who are living with HIV, those who are diagnosed with HIV, so they've been tested and been given a positive diagnosis. And then over time, those who are retained in care over a specific period of time. And then of that subset of folks who's actually retained in care, those who've suppressed the level of virus in their blood enough to stay healthy, to live long and very healthy lives, and are unable at that point to transmit HIV to others. And we see here in Montgomery County that of those living with HIV, only 57% approximately have achieved viral suppression, which is a major charge for us to do better and to do more. And so we link folks to care really well in the county. When we diagnose someone, we get them into care. They stay in care for 3 months, but over time, retaining and keeping folks healthy is a challenge for us. This is a map of the county where we see over the past 5 years, like sort of hot spots of new HIV diagnoses. I think there's so many caveats to mapping data like this, but it gives you a sense of, what neighborhoods are most impacted, what the service landscape might look like if we were reaching people really close to their homes. But there are a lot of questions that it doesn't answer. And so I don't want to go too deeply into that without all of those caveats. But this might look similar to some other maps of the county that you've seen if you're focused on health equity in other areas. So among women and among all people living with HIV in Montgomery County and all people who are diagnosed with HIV in Montgomery County and around the US, there is a massive racial disparity in who's contracting HIV and how well they're doing after they're diagnosed. So we have a ton of work to do in health equity and racial disparities in particular with HIV. So for perspective here, Black women make up 20% of all women in Montgomery County, more or less, and 72.7% of new diagnoses among women, and 80.9% of women living with HIV in the county. This is unacceptable. And to be very clear, this is not due to differences in behavior or risk behaviors, anything like that. It's much more about structural inequality, access to care, segregated sexual networks, et cetera. So I don't want anyone looking at this data and thinking that there's this is just about risk behavior. This is a much deeper issue that gets to a lot of racist practices in healthcare and structural racism overall in health and wellness in the country. So, so it's a core part of our plan to address equity. So our plan, and I have to I have to say that this is whenever I tell people that we're working to end the HIV epidemic in Montgomery County or anywhere in the US, it's like a mind-boggling thing to say, right? And ending an infectious disease, ending an epidemic is complicated. And there are many people living and thriving with HIV. And sometimes this phrase, ending the HIV epidemic, seems exclusive. And I wanna just say that this is, you know, it's a complex program, and we want to do better for people living with HIV in the county. We want to make sure that they have access to everything they need, and ending HIV doesn't mean ending services for people living with HIV. So we got together as a county a few months ago and started drafting a plan with a lot of our community partners to come up with a vision and a mission and some values for, like, what does it mean to really use all those tools in our toolbox to end HIV by 2030. What values do we want to include in that? What does it mean to end HIV, right? So if we want to achieve a Montgomery County where new diagnoses are in fact rare, and when they do happen, folks are diagnosed and surrounded by all the resources they need to stay healthy and prevent transmission to others, without judgment, without stigma, without other barriers. We have to be transparent with our communities. We have to be person-centered and recognize that HIV is just one part of someone's life, whether they've been diagnosed or not, and non-judgmental, right? There's a lot of stigma and a lot of judgment that goes into HIV service provision and even thinking about and talking about HIV that we've never gotten past as a society. And we have to move through that and address that. And most importantly, we are working against a tide of inequity in this county and in this nation. And if we don't talk about that openly and we don't work against it, we'll fall into it and we'll be swept along with it. So our plan is very bold, and it is really about constant communication. And so this is an example today. If you're listening and you want to put, if you want to read and give us input on the plan, I will give you the link to do that, because we are always open to additional feedback. The Ending the HIV Epidemic program is divided into 4 pillars: diagnosing, treating, preventing, and responding. And our plan, in a very short nutshell, is if we want to achieve 95% of people living with HIV knowing their diagnosis, or being diagnosed and knowing their status, we are going to implement routine opt-out screening in healthcare facilities in this county. So meaning that you don't have to walk in and say, I think I need an HIV test. Your clinic is already set up, as was recommended by CDC in 2006, to screen people as part of routine care, whether they ask for it or not. We have a lot of work to do in that department. Scaling up our community-based testing that is voluntary and that goes on in the community, especially in communities that are priority for us in this fight. And improving culturally sensitive partner notification, contact tracing, which is something that's on a lot of our minds because of COVID. and of course increasing awareness of all of this stuff, but especially testing. We gotta do better and find people earlier. If we want 95% of people diagnosed within care in 30 days and 95% achieving viral suppression over time, we got a lot of work to do. We have to establish countywide guidelines, use the data and resources available to us to engage people who've fallen out of care, expand access to all the services that someone might need that maybe are not related directly to HIV, and build capacity of our county's many HIV clinicians to make sure that we have the most up-to-date and state-of-the-art HIV workforce in the county. And on the prevention side, so many areas of work to do here. So expanding those biomedical resources like PrEP and PEP, post-exposure prophylaxis, condom access, and then things that address the root causes of HIV in our most vulnerable communities, like LGBTQ-friendly healthcare in the county. What does sex education look like? How do they talk about HIV in schools? Expanding syringe exchange programs, where which are really, really valuable in heading off a lot of public health issues of the past, and then increasing awareness again through a comprehensive campaign. So this is just a quick snapshot of our plan. You can find it online at tinyurl.com/EHEMOCO. Again, you don't have to write this down. I'm going to send this out. And ways that you all can get involved, especially those of you who are, again, part of our robust HHS workforce and our community partners throughout the county, or you're serving Montgomery County residents and other parts of the DMV. Come to these trainings, get your CEUs. We're going to do one every month. We're going to talk casually in these panel discussions in the beginning of the month, but we're also going to do webinars that get a little deeper into some of these topics. We're doing one on trans healthcare in May. We're doing one about youth and HIV in April. We'll be covering the gamut of topics, and you can also sign up for our newsletter to get updates on those. And if you're interested in learning how to incorporate testing into the services you provide in Montgomery County, we would love that. Please feel free to join our Testing Linkage and Care TLC collaborative. That's when we meet. And you're about to see everywhere our new sexual health campaign, which is designed to raise public awareness about all the topics that we just discussed. And we are getting a new website, new social media platforms, and really moving forward with everybody's best skills. And that includes our health officer, Dr. Travis Gales, who has a really strong HIV background and is really passionate about ending our HIV epidemic. I am going to enter into panel mode now, and I will be asking questions of our illustrious panelists, and you can use the Q&A function also, as I mentioned, for those of you who are joining later. We have Q&A carved out at the end as well. So yeah, thanks again, panelists. I'm gonna get started. The first question is for Dr. Rosen. Okay, so we talked a lot about diagnosis and the importance of that period of time after someone's diagnosed. So when you're first seeing a patient who's newly diagnosed with HIV in Montgomery County, what does your first appointment usually look like? And what kind of concerns do you see newly diagnosed women bringing to their initial appointment?
Thanks, Emily. So our first visit is usually actually a fairly long visit, because we're trying to gain information about them, about the person, and most importantly, give them a lot of information too. I always start by telling them that, I have a lot of training and I've had a lot of experience, but I'm not the one sitting in their seat. So I want them to be able to feel in control of their health. It's a time that a lot of women feel, and men, of course, since we're talking about women, feel very out of control. That the world is upside down, and but I want them to learn that they do have a lot of control through education and through action. So the visit starts off with a detailed medical history to make sure we know all that we're dealing with, an exam, and we get a lot of labs at that point. But the visit, the majority of the visit is about education. So kind of one of the things that I like to do is see how much knowledge they have of HIV. You know, depending on what community they're from, they may have more or less knowledge. They may have a lot of misinformation. So I like to hear about where they're starting from. And then I basically, for most of my patients, I'm able to really give them a lot of hope in the end by giving them, you know, telling them about the prognosis of patients of people who are taking medicine. You know, I tell them, you take your medicine, you see your doctor, you're going to do great. You're going to be, you're going to live the life you were expecting before your diagnosis. So, you know, I also give them their prognosis without taking HIV and kind of talk to them about the natural history of HIV and how it can progress to AIDS if it is ignored or not cared for. I talk to them about transmission, so how they how they could have been infected or how they could transmit it, but also more importantly, how they can't transmit it. You know, a lot of people may feel a lot of guilt or other feelings, and they don't want to tell anyone about it, but they then worry that they're going to spread to someone else in their household. And so talking about how, you know, sharing bathrooms, sharing kitchens, all of that, you can't transmit HIV. You can hug your grandchild, you can do all of those nice things. And so talking about then also, you know, we also have more information about U equals U, meaning undetectable equals untransmissible. So people living with HIV who are taking their medication, and it's rendered their virus undetectable, are not able to transmit HIV sexually. So that gives people a lot of kind of hope for kind of a normalcy in their life. You know, we also talk about the stigma because, you know, in our safe clinic, all the patients who come to our clinic have HIV, and so we're a very welcoming community, but they may experience many other things in their communities. So kind of talking about disclosure and who they feel comfortable disclosing to and who they do not. And for each woman, it's very individualized. You know, some women may not feel comfortable telling their partner because of domestic violence issues or other things. So kind of talking them through all of those things. I also like to figure out, you know, again, what their pre-diagnosis plans were, what they wanted to do, if they're young, what they want to study and what job they want in the future, and kind of reassure them that all those things are still realities for women who are single, but are interested in having partners in the future, talking about dating and how you can still do these things, and also see if they want children. So for people who don't want children, I want to help them not have children. For people who do want future children, I want to reassure them that that dream that they had about having a baby can still be a dream of theirs. So I think what we really try to do is start off with a lot of education. The other big thing that we're starting to do more of as our medications become easier to take, less side effects, and more effective, we're starting to get women on medications earlier and earlier. So for a woman who feels ready to take medicine, I'm ready to give her medicine that first day after we've had these conversations. We know that people who start medicines as soon as possible are more likely to get their virus undetectable as soon as possible, and also probably more likely to stay in care. So there's a lot of education also about adherence and staying on the medicine so that that the medicine works well for them. And we also refer them to mental health services if they need, substance abuse counseling if they need. We have you talked a little bit about partner notification. So if those services are needed, to anonymously tell a partner that they need to be tested again. So if we're worried about issues of domestic abuse, et cetera. And then we're lucky enough to have the services right in our clinic with the mental health, substance abuse, dental, and nutrition counseling. So we try to get them hooked up as much as possible, if not that first visit, in the next few days to weeks.
Awesome. Thank you so much, Dr. Rosen. And so, Miss Paulette, my next question is for you. So, as someone who is living openly with HIV, or as someone for whom HIV is living with you, you probably hear a lot of questions and maybe some misconceptions about what it's like to live with HIV. What kind of things are you hearing, and how do you respond to some of the myths and misconceptions that are out there?
Okay, me being openly with it, that was a process. It didn't, as soon as I got diagnosed, I wasn't ready to blab it out to everybody. But that took over the years after I was getting comfortable with myself first. And I was told when I was first diagnosed, I was told I would live only for 3 months. So after 3 months came and I was still living, oh my goodness, I'm going to take care of me. Come on, doctor, let's do what we need to do. And I was able to share it with my family and my children. But things that I'm still hearing today is, can I get it by kissing? And I'll tell young people, kissing, well, don't you want to look at somebody's teeth before you want to kiss them? I said, but no, you can't get it by kissing, but you still want to, if you're going to kiss somebody, make sure breath, ain't no breath coming out their mouth and all that, and the teeth are not dingy and dirty with all that gunk on it, so you got to look out for stuff like that. So yeah, you want to kiss somebody got nasty looking mouth. And of course, if they've been drinking, they ain't even gonna think about that. A kiss is a kiss. So I tell them, no, you can't get it by kissing. You can't get it by holding hands. You can't get it by sharing a glass with someone. You can't get it by using the toilet. They're going like, really? Yeah. I mean, all those fears, all those questions I used to ask, when I first got diagnosed, and learning more and being educated about my HIV. So now I can go out into, I go to a lot of 12-step programs, women's raps, and I share with them, that I'm HIV positive. They be telling you lying. Oh, you just, no, you're not. No, you're not. Or some of them will come to me after the meeting is over with, and they'll slip me their number. Can you call me later on? I said, sure. Then I find out, are they in care or seeing a doctor? No. Okay, we're going to get you hooked up. We're going to get you into some services. And I just advocate for them. I go with them for their first visits. Whatever is going to help them. And I also tell them being HIV positive is not a death sentence no more. They got very good medicine out here. And, it's a lot of the people who are undetectable. I was hearing people say, oh, I ain't got it no more because I'm undetectable. So I had to now go back to the doctors and say, you all need to explain to us what undetectable means, because I'm hearing so many people telling me, well, I don't have it no more. Yeah, you still have it, but you don't have much in your body, and you can't pass it on, but you still want to maintain safety. You still want to practice safe sex because you can get them other type of diseases that you don't want to get. So, safe. Practice, practice, practice.
Thank you so much, Ms. Paulette. And the next question is for Chantel. We talked a little bit about pre-exposure prophylaxis, the HIV prevention medication. And as you know, it's often marketed to men because of their increased risk relative to the general population. But we know that women are at risk of contracting HIV also. When, in your opinion, in your experience, when should a woman consider taking PrEP, and what might that look like?
I think that like all women should, consider taking PrEP, right? And so I think that's half the battle when it's only prescriptive to your area code. We've done several studies in the DC, Maryland, and Virginia area, and we took away zip codes, we took away degrees, and we looked at like, what are you doing in the bedroom? And a lot of those behaviors were still the same, right? So that means my exposure, I don't like to use the word risk, but it's just as great as someone who maybe live in a zip code where the prevalence is high. So I think the conversation should be germane to anyone who steps through our clinic doors. And it's not a conversation that we only pick and choose, someone's educational background, if they have like 1 or 2 partners, or if they live in this area, then I'm just going to have this conversation with you because you presented here maybe twice with the same STI. I could have had the same partner and he could have told me something, and I may just choose to believe that he's not stepping out on me. And I just keep getting this mysterious STI, right? But I think the conversation is needed for all women, especially when it comes to Black women. I feel like a lot of times we're often left out of conversations, which leads us not to want to be included when the time comes. Or it's very like, it's condescending. You need to do this because you're at risk, you're doing something wrong. No. I want to be engaged proactively in my healthcare. I think the approach is just as important as well. So if you're engaging me and you're being intentional with how you talk to me and leveraging me in my own healthcare plan, I may be more inclined to take it. So I think it's all women, and it needs to be different entry and touch points, right? So, messaging is really big and important. So if my friend hears something different and someone over there hears something different, I'm going to kind of be like, I don't know if this is for me. But if the messaging is the same and I'm constantly hearing it from different touch points, I think I may be inclined to take it up.
Thank you so much for that. So it sounds like, and I agree with that. We should be doing better at messaging all women and making sure that we are talking about it more and not just like this risk group or that behavior that gets flagged that it needs to be. And that's definitely a core part of our plan that I'm really excited about. Thank you for saying that. Dr. Jones-Parker, so the CDC recommended in 2006 that primary care clinicians should routinely screen people for HIV in primary care settings. But we know that that's not happening nearly enough in really anywhere. And so I'm wondering, in your experience, I know you work with clinicians to try to increase behaviors like that. What are the barriers there? And what do you think is keeping clinicians from testing routinely for HIV?
Thanks, Emily. So 2006 seems so long ago, but I remember when that recommendation came out and it was like, okay, we can do routine testing. It would have seemed it was something we could have taken care of in 12 months and everyone would be doing it. But fast forward 2021, as you just said, people don't really routinely test for HIV, and old habits die hard. And there are a lot of different barriers. I feel now that there's been a little bit of breakthrough with this whole COVID-19 situation because people have a new understanding of infectious disease and how it can spread very quickly. And it doesn't matter what you look like, how you can get it. And we just want to be able not to do that. So I feel that there's a newfound understanding of infectious disease and everybody wants to learn more. Everybody's interested in prevention. But HIV, I found that since I've been doing training for providers to get them to routinely test, you need a champion. You need a person in the clinic that believes it to their core that HIV should be prevented, and the way we can prevent it is to test everyone. If you have that person that really believes that, they are going to promote it when I'm there and when I'm doing training. But 10 years down the road, when I see that same person, I've had people come up to me. It's like, yeah, I remember when I was at X clinic and you came in with did training, but now I'm here. And they singled me out and I'm running the program over here. And I tell everybody to test for HIV. And it's not because of anything that I taught them. It's because it's something that they really believe. And those people are out there and they are in every clinic. And it's finding that person, because if that person will champion routine testing at that clinic, they're going to champion it wherever they go when they leave that clinic. And then they're going to find other people there and pull them on. So the program doesn't die. A lot of routine testing initiatives, when you pull out the funded initiative, it dies, right? Unless you have the people there that really believe that they should be doing it. And through the years, I've found those people and they remember. I remember when you were here doing testing, but you all don't come anymore. So it's like, I'm the only one, or this group of people, we're the ones that say, you need to test that person. It's just a box, click it. There's nothing in addition needed. And the other part of that is that I found if people have it as a part of their fundamental training, that's what they're taught to do as a part of their medical training, then that's what they're going to do. They're going to do that just like they take care of diabetes, just like they test for cholesterol, because they were taught to do that. So I worked really hard for in our nursing school and our medical school for them to have that foundation about this is the way you do it. This is the way you take care of HIV. These are the 4 pillars. So coming out, they have that knowledge. And I feel that as doctors and nurses and PAs and providers come out of school now, they will have that foundation. So what we're seeing is going to be a steep curve going up of routine testing. It does help when you have things like EHG funding that goes to a primary care clinic and say, here's this money, then everybody wants to routinely test. And you're like, come on in, Hazel, let's do routine testing. But I feel that this time it's going to catch on and it's going to kind of stick. Because we're going to have more and more of a workforce out there that has been trained to do that.
Excellent. Thank you so much. And I feel like that's so powerful because we often, when we talk about HIV testing, we're putting the onus on the person to say like, I think I should get tested for HIV, which is great. And if you're empowered to do that and you want to get tested for HIV, like there should be lots of mechanisms for doing that. But there's a huge proportion of us out there who wouldn't think about that. And we have a lot going on and it takes both types of testing. So if you're out there and you're attending today's module and you're in a primary care setting and you want to talk about what routine opt-out screening might look, please get in touch with us. It's an important part of our plan, and some great clinicians are already doing it in Montgomery County, but we need more of y'all. So thank you, Hazel. So circling back to some of the other areas along the continuum, Dr. Rosen, as we talked about, we have kind of a problem with retention and care and viral suppression in Montgomery County. It's not unique to Montgomery County. It's a problem everywhere. But I'd love to hear your perspective on like, what do you think causes folks to fall out of care? Given that we have all these great tools to stay healthy, what are some things happening in your patients' lives that when you see that happening, what's usually happening?
I think there's a few different things that women can encounter. A lot of it is mental health issues. So depression, anxiety, and then substance abuse issues. I think all of those can really interfere with adherence to medication. One of the other things that we encountered newly, I don't want to get political, but we encountered newly a few years ago was because we have such a large population of foreign-born patients, and some of them are undocumented. There was a lot of fear of the consequences of signing up for something, about showing up and potentially getting deported. So that was a very, very scary time for many of our patients. And I think we lost a lot of our patients to care for quite a while because of that. There's a lot of mistrust in the system because of disparities. There's a lot of mistrust. And I think there's a lot that we can do to try to regain that trust. But, for an individual patient, I think the more we have community outreach workers who can go into a person's own community and help out, I think that is incredibly powerful. Someone else who's been there, done that, I think that's another way that we can reach some of these folks. But again, as you were saying, our numbers really drop off when it's about the retention and care. A good provider-patient relationship is also very important, but I can have a great relationship with a patient, but if she relapses in drugs or alcohol, or if she loses her insurance and can't get to her psychiatrist anymore, or if she has other reasons for fear, maybe fear of, her boyfriend saw the clinic phone number and was wondering what it was, so I think there's a couple of many different reasons that we can see that. And, as with the EHE initiative, funding toward more community outreach workers who can, and people who can look to find who these people are and help get them back into the care will really be wonderful.
Thank you so much, Dr. Rosen. So something that kind of goes throughout the continuum, Paulette, and something that we talk about constantly, but it's maybe hard for the average person to define is HIV stigma. So I would love to know from your perspective, I mean, you work with folks all the time who are newly diagnosed, you work with healthcare providers, you work with people across the spectrum. Where does HIV stigma show up? What does it look like? How do you know when you're seeing it? How does that feel? How does it look to you?
Sometimes it can be in the doctor's office itself, how a person is treating you. And it's like, I know for myself, I would get a certain feeling. I'm going like, okay, well, you ain't treat that patient like you do me, or you doing something extra and different for this patient, and why you not doing the same thing to me? So just giving me a bad feeling. Or I know, like when I first got diagnosed, I thought I had the word on my forehead, right? I got on the bus and I just knew everybody could see I was HIV positive. I was like, it must be on my forehead, because when I got on the bus, everybody just stared at me. I'm going like, oh my God, they know I got it. And I was working at this job, and a girl had befriended me. And then I noticed people was coming in with their masks on and gloves on, and in my space, in my area. And when I touched something, they would go and wipe things off. I'm going like, now, wait a minute, am I getting paranoid, or is this really happening? And it was really happening. I said, oh my goodness. So I had to like educate them, bringing little pamphlets at work and leaving them in the places that people have lunch break and things like that, to try to educate them. Stigma is just like, oh, she got that thing, and what is that thing? Put a name to that thing. I had a brother who used to get mad with me when he'd get drunk, and he'll say, you old AIDS looking dying bee. And I brought him to my bedroom one day. I said, come here, let me show you something. Now he all skinny and frail, right? And looking like he about to leave, check up out of here. And I said, let me ask you something, brother. We looking in the mirror. I said, now who look like they got what? I said, yeah, I have HIV. Well, what do you have? Look at you and look at me. And don't you know that stopped him saying those things to me? Because I was looking more healthier than he was, right? But stigma is really, nobody want to feel that, because people, they're short in their expression, or you heard the whispers, and I tell people, when people hearing the whispers, make a song out of that. Oh, I'm whispering today. Bust them out, right? Oh, I'm whispering today. And they'll catch people say, oh, no, they hear what we're saying. We got to stop saying that. You got to embrace that stigma and call it out, call it out. So that'll make that person know, don't do that no more, because we do have feelings, So when you start to let people know that, okay, I have it. Okay, do you know what you have? When last time you been tested? I put it back on them, right? So that fear and shame, the things I used to feel like that years ago, I don't feel that now. Like sometimes I forget that I have it, but I know that I take my medicine at night, right? And I hear people talking about, I say, oh, okay, well, let me get you into some service. Then I say, well, hey, I got it too, so what's up like that, because it's not in the front of my head. I don't go around thinking about it 24/7. It's now in the back of my head. I know that I have it, and I know I must still take my medicine. And that's how I carry it, trying to take better care of me. Yes.
Thank you so much. And thank you for sharing your experience with us. And we know we have lots of data about how stigma affects people's likelihood to get tested, likelihood to stay in care, and in both internalized and interpersonal stigma, institutionalized stigma. And we have a lot of work to do in making sure that the way we talk about HIV in the community through EHE isn't making it worse, right? Because the fear and the shame that people feel about HIV and sexuality and infectious diseases in general, it all gets really kind of rolled up into this emotional barrier, right? And I appreciate that you shared that, because I think that we underestimate, how important that is even today. I still hear people, kind of they'll say the whole sentence, but they'll whisper the word HIV, even in like the clinics that I've worked in. You know, it's like we can't say that part out loud sometimes. So I think that that's a great point. And you know, if we think about how hard it is to have these conversations with our own families, like that's what everyone's dealing with. So so thank you for that. And stigma is, you know, it's not just about HIV specifically. Chantel, a lot of people are concerned about sexual stigma and shame and just like sexual behavior. It's this double-edged sword. So a lot of people are concerned that if people start taking PrEP, for example, pre-exposure prophylaxis, that they'll stop trying to protect themselves from other sexually transmitted infections. And I feel like that's something that's tied up into our general discomfort with sex and sex as only a risk behavior and not a part of a healthy life or pleasure, God forbid. So what do you think about that, Chantel, when we talk about PrEP? How can we kind of like untangle that? What are your thoughts on?
So we're on the heels of what was National Women and Girls HIV/AIDS Awareness Day. So I'm going to say for women, I want to be politically correct. You know, hands down with patriarchy, you know, I would say F it or something like that, but this is my body, you know, and it's body autonomy, and we should be able to do what we want with our body. It's a lot of things are rooted in patriarchy, right? And so that itself breeds, gosh, everything that's wrong with our system today. Menstrual cycle, men, you know, menopause, everything that's wrong with us kind of starts with MEN. But in all seriousness, I think that we have to push messages that encourage one to engage in their healthcare and in their body, right? For so long, like we're taught that it's not our own. So how can I protect and love on something that I'm really told from the time I come out to, like, I'm told what to do with it. Don't wear a skirt above your knees. Don't do this. Don't do that. Don't talk about your period. Don't do this. Well, then you get me to a space and you're saying, well, you should know what to do. You've been telling me this all along. Keep going, right? So I think it's important that from day one, we send messages that encourage women to have a hand in their care and to do whatever it is they please with their body. I think taking the lens off, you know, and destigmatizing what people do in the bedroom is key. Because I'm working in PrEP and working at the clinic, I've seen people who come and they've become more safe on Truvada. It's more touch points. As I keep going back to touch points, I see those people more frequently now. So every 3 months, I'm seeing them now, and they're coming in and they're checking up on this. And then I build rapport and relationship. And before you know it, it's, well, can you help me with these other priority needs, right? And so now we're getting wraparound services, co-located services, and it's a whole, like, you know, deal of me guiding my health practices, right? And doing what I want to do in a healthy manner. So it's giving me the key to do what I need to do for me. And women don't have that privilege all the time. It's always dictated by someone else, or we're always giving that key away. So I think, you know, putting the power in our own hands to protect our body is key, and it's a game changer. It amplifies our voices, and it unlocks things that we may be wanting to do. So even if I'm getting on PrEP, it doesn't mean that I'm doing these things. It may, you know, be that I want to do these things later down the road, and if so, that's okay. And if your feminism doesn't include supporting all women, even when her ideals are different from yours, then you can't call yourself a true feminist. You can't say that you're for all women when you yuck other women's yum, right? And so you have to really be there for your sister. So though she may have 60 partners, and I'm just, you know, exaggerating, that's okay. You can't say, well, sheesh, you know, it's having a risk reduction program and making sure that she is protecting herself. And what's that like? And exploring the option, well, you know, maybe it's not for me, but knowing, like you said, there's a toolkit. And are you utilizing everything in that toolkit? Are you teamly testing? Are you using condoms with a percentage of your partner? Like, you know, what other protection mechanisms besides condoms and PrEP do you have? Are you using dental dam? Things like that. You know, what spots are you testing? Are you doing all-site testing? I think when you engage a woman in her whole health and you explore everything that she has, you empower the next generation, because we talk to our girlfriends, we talk to our hairdressers, we talk to our cousins, so we're going to tell everyone about these things. And so when you empower one, you empower all.
Thank you so much, Chantel. And I mean, a lot of people have said this, but I feel like it's worth repeating that the way that we talk about PrEP now is a little bit analogous to how we talked about contraceptives a long time ago. And you know, people thought that there was going to be this massive problem with changing behavior and going off the rails. But in fact, it empowered a lot of women to take control of their health, and that's our hope for PrEP as well, right? Like you said, if you provide a non-judgmental place for that tool to be available, it could actually improve access to other things that they might need as well. But I hate to think that there are women out there, and I know that there are. And honestly, I mean, to some extent, I think we've all been that woman who is afraid to seek something like that, afraid to ask for it, and because of all of those pressures that you mentioned. And I think that that's really critical to create spaces where that feels less oppressive. So thank you for being a space like that, for creating a space like that in your clinic. Hazel, as primary care clinicians in our county, speaking of creating spaces for non-judgmental care, grapple with what it means to end the HIV epidemic. What advice do you have for addressing HIV, STIs, sexual health in general in a primary care setting? Because we know that's another thing that doesn't always happen, right? How do you roll? Oh, you're muted.
Absolutely. I feel that these are issues. They're women's issues. They're important issues. And if we're going to empower ourselves, once you're all pumped up and you're feeling empowered and you go to the clinic, it's quite often that you get shut down by a provider saying, well, you don't need that, or why did you come here for that? Or we don't do that here, or we can't see you today, or today we're just going to do this. And then everything that you've built up to is kind of wiped away and you feel defeated. So what's that about? That's about finding a provider that you can identify with and that you can build a relationship with. And I feel that in today's world, we're living with pandemics, we're living with institutional racism that's open, right? So we don't know how we're going to get treated. And it doesn't matter if I'm a provider, if I'm educated, I can die of something just as another African-American woman because we're more at risk for heart disease. We're more at risk to die. You just told us what the percentage of HIV. We're more at risk to die in childbirth. We need providers who understand that and is sensitive to that. So then you talk about cultural sensitivity. I need a provider that is going to identify with me. And for a lot of people right now, that may mean a provider that looks like me, okay? But we know that providers that of African American or Black and Brown providers are in the minority. So that's not what's going to happen. So what are we doing? We need people like Chantel that provides those wraparound services that can provide that support for those providers that are giving those services and are generally vested in the care of their patients so that they can come in and they can get those HIV services, they can get those STI services, they can get that 3-site testing and not be judged by it and know that we're doing it. I'm doing it so you can live, okay? I'm doing it so that you can live your normal lifespan because there's a lot of people out here that really do not care or are not interested. And yes, some of those people are providers and they're going to kind of push you to the side and move on to the next person. Like Miss Paulette said, hey, why are they getting more attention to me? I have the same problem as them. What did I do? Why am I different? Is it because I'm a woman? Is it because I have HIV? Is it because I'm Black? Is it because I'm Latino? It's probably some combination of all of that, even though, and the provider may not even know it, because you can talk about things like implicit bias, right? I don't know that I'm doing that. I don't feel that I'm doing that, but yes, definitely it comes across like that. So if you have these implicit biases, it shows by the way that you care for your patients and the services that you give them, the places that you refer them to go get care, that you may refer somebody else different. Well, why did you get to go to Rockville and I had to go to Clinton or whatever to get some sort of testing? And they said that the testing in Clinton was bad and the machines were old. But but this person got to go to the new place in Rockville. Why didn't you send me there? So those things happen all of the time, and we don't know that they're happening. So still with HIV, STIs, sexual health, if you're not comfortable talking about that with your patients, with women, with Black women, you're just not going to talk about it. I have providers in my practice, they don't do pap smears, they don't talk about sex. You know, you go somewhere else for that. But you want to be in a place where you can get more of a holistic care, and that they feel that you're cared for. And unfortunately, it's hard to find those providers if you want one. So most of my patients are women now. Most of them are like African American or Latinx, right? Because they want to provide that kind of looks like them, identifies with them, can kind of understand their lived experiences. And of course, I understand lived experiences, but for the grace of God, I'm sitting on the other side, all right? You know, because I have the same risk factors as you, right? I am no different. I am African American. I live in Maryland. I'm in these counties. So it could be me. So, and I understand that. So having that lived understanding experience and knowing that you're just at risk, I think it's important to find a culturally sensitive provider that can provide holistic care, including your HIV, STIs, and not be judgmental. And I just find it really hard now when patients that are infected or at risk too. Remember, all of our at-risk patients, they still need that care as well. It's kind of hard to find those providers. And I think that's something that we need to work on.
Yeah, thank you. I completely agree. I want to give folks a chance to ask Q&A in the Q&A section here in the chat, whichever you prefer. And you know, I also just want to charge folks who are listening to think about that too. This is, like I said, our first iteration of this series, and we have such a huge, robust, and multidisciplinary workforce here at the county, and you're a member of it, and you all are embedded in clinics and treatment centers and schools and other places where HIV and STI services, PrEP referrals, sexual health information could be shared. I would love for everyone to think about ways that you can take this information away or partner with us at the health department to get this information out. And Hazel and AETC offers all sorts of great opportunities for professional development, because the literature on this issue shows that absolutely that clinicians are by and large reticent to talk about sexual health with their patients, and that they're no different from most humans in that regard. So we have some institutional change to make in that area as well. And if anyone on the call is in behavioral health or other parts of the county's workforce, like there are so many great overlaps that we can partner on to make sure that there aren't missed opportunities, right? So if folks aren't getting tested in their clinic and they're not getting tested through outreach, it may be that you're seeing the same folks, the same patients and clients repeatedly, and they're getting sicker and sicker because we're missing opportunities to diagnose them with HIV, or maybe they've fallen out of care and maybe they're looking for another welcoming person in their lives to disclose that information to. So I think our whole county, we need all hands on deck, and yeah, I'm thrilled that so many folks attended today. We did leave an optional 30-minute Q&A session at the end in case anyone wants to ask the panelists something, but I'm not seeing any questions come in, and like I said, this is the first, so we have lots of opportunities to communicate with everyone. Do any of the panelists have any questions for each other?
Yeah, I do.
Sure.
Hi, I just want to say to Dr. Jessica, you was talking about how people are getting out of care. And my experience with that was patients don't like to come in the office and be waiting a long time, I know for myself, if I'm in the doctor's office longer than 30 minutes waiting, oh my God, I'm ready. What the heck is going on? I'm sitting there, my appointment was so-and-so time, and I get that things happen, or the other patient has some additional issues, but I think it should be respectable for even the receptionist to say, well, the doctor's running a little behind, and you want to make another appointment, or do you mind sitting for another 10 minutes? giving us that option and choice. Also, they're like letting people know you got an appointment coming up, just checking behind them, especially ones you hadn't seen. Well, how you doing? People change their phone numbers, I would go out and knock on the doors where they live at and say, girl, why you ain't been back get some care? What's going on with you? Well, transportation, anybody to watch the kids. Okay, I'm gonna make your appointment and we're gonna bring the kids along with us, So it's a lot of reasons why people fall out of care, or they just get tired of taking medicine. But now medicines have gotten better, but it's the appointments, long drawn out appointments, or the appointments get canceled and the patient didn't get notified, or they forgot to get notified. So it's a lot of stuff that goes on in the office itself, and with myself, when I go see a new doctor, when my doctor retired, whatever, I make sure if you ain't checking my eyes, if you're not weighing me, if you're looking down my throat, I'm going, what's wrong with you? You forgot to do this. You forgot, you should be doing this. You should be doing that. And they be going, like, sick of her, be telling them how to run their clinic, but it's important that y'all look down our throat to see if we got any candidates or any swelling going on, check our lymph nodes and all that kind of things. Because we don't know, we coming to y'all we're looking at y'all professionals to help us,
Absolutely.
And I just know when I tell clients and patients, write down anything that you notice different that's going on with your body, write it down, or write down what time you notice it, so when you go to the doctor, y'all can have that conversation. Instead of trying to remember, write it down and go to the doctor's office and tell them, what you feeling, the medicine is making you feel sick, let them know. Y'all can't read. I said, the doctors cannot read your mind. So you need to start opening up your mouth and talk. I be trying to help them to advocate for themselves, yeah. But y'all talking about the young people, we got a lot of seniors out here too that's still coming up positive. And I go to the senior citizen places and I say, I know y'all girls still try to get your thing on and all that. I be dropping like it's hot and all that, having fun. And they're going like, yeah, I still get a little bit every now and then. Okay, are you using protection? No, girl, we don't need that. We too old for that, baby. I be telling them about the female condom. What? Put that thing up in me. Yes. And I just be honest with them, keep it real, and have some fun when I'm talking about sexual behavior. And the old people going like, all right, girl, I'm gonna try that. I like you. You so open. You ain't embarrassed to say nothing. No, I'm not embarrassed to say anything. If it's going to help you, let's talk about it. Yeah.
Thank you so much, Paulette, for your input. I appreciate it. I want to actually, talking about those long appointments and sitting in the office, I think surprisingly for some of our patients, COVID has been helpful in getting them back into care, which was very surprising, because now we're able to do, we didn't do telehealth before, and telehealth with a video camera, or telehealth even just by phone. We've been able to reach a lot of patients who for many reasons weren't able to come in, felt too busy with work or too busy with childcare, or the transportation was too much. One reason or another, we've definitely been able to actually get people back in care because of those issues. So I really do appreciate that. Yeah.
That is an amazing thing to learn, right? If we had to have this experience of another pandemic on top of all of this, then yes, I think that's a huge lesson learned. So thank you for that. And Paulette, I want to give you a special shout out, just because you are reaching people in a way that no one else can. And I just appreciate your work so much. And we have a lot to learn from your input. So thank you especially. And yeah, again, I want to say thank you to all of the panelists and to those who attended today. You'll get a follow-up email with more information and information about CEUs. Thank you again to our partners at AETC. And last message, just want to say, you are, if you work in Montgomery County in social services or healthcare, you are serving people living with HIV. You do have clients and patients who are women living with HIV. And some of them know they are living with HIV, some of them don't. So we really need everyone on the same page here. And we appreciate your support by attending today. Partnership opportunities abound within and throughout the county. So please reach out. And I want to say thank you again. I see some great comments coming.